Okay, so my name is Brandon. I guess just for this assignment that I'm talking about co-occurring diagnoses with mental health and substance use, I'm kind of figured that this is something that I should probably focus my energy on, especially since this is something I want to be working on in the future with. And seeing individuals, even though we're not treating for substance use services right now, but seeing individuals that still have those issues come into our door and being able to be a little bit more aware of things that they might be dealing with, even though I might not be able to offer the services that might be able to help them deal with their substance use, but be more mindful when working with their mental health. So the first article that I wanted to focus on was from the SAMHSA website. It was co-occurring mental health and substance use services. They provided some background information. It was currently in mental health. We're currently in a mental health and substance use disorder crisis, and it's affecting all age ranges. Throughout a lot of the literature that I was seeing when doing this, it was talking primarily about 12 to 17-year-olds. So to me, it was kind of scary seeing that come up a little bit throughout each one. I was assuming that was going to be more 18 plus and probably more people that are 20s, 30s. But a lot of the literature focused in that 12 to 17 range when talking about these services. Um, from February 2022 to 2023, anxiety and depression diagnosis increased by a little more than less than 1%. Many people who have had anxiety and depression have also reported marijuana or alcohol usage. Um, they out this during this time they were also looking at some of the related stress from COVID-19. They said 3 out of 5 individuals reported alcohol consumption when dealing with stress related to COVID-19. It addressed some of the fentanyl and xylazine being in the drug supply. I know when I was doing my paper for the research literature review, I focused a lot of energy in that fentanyl and xylazine um, information that was being provided through sources, and especially since it's been more of a recent since like 2019, 2020 time, especially reading up on that and seeing that it's more of a cheaper substance to cut fentanyl with, and it being more easily accessible across all ranges of age kind of lines up with the fact that we're seeing a lot of affecting all ages, both substance use and mental health. Um, Talks a lot about like poly drug use, especially since xylazine is kind of known for kind of advocating in a sense for poly drug use because you see it um, you see more substances, especially stimulants being used alongside xylazine, even with it being mixed with fentanyl. Some of the recent data provided, like I said, about the 12 to 17-year-olds, and it's a very big concern with depression, suicide, and substance use. The data given in 2022 was 21% of adults 18 plus experienced either mental health or substance use disorder. 107,622 drug overdose deaths in 2022, and 13.2 million serious thoughts about suicide. So that's just to give a little bit of a data update of what was experienced in 2022 that SAMHSA was talking about. Um, Kind of scary when we start talking about hundreds of thousands of people dying from overdoses. And that's just overdose, not talking about mental health. Some of they actually defined co-occurring disorder. It was very much similar to what we have in the book. It said someone with common co-occurring mental health disorders and those who have substance use problems is kind of was very from the book almost. They mentioned ADHD, depressive disorder, anxiety disorder, personality disorder, bipolar, trauma, stress related disorder, psychotic disorder, eating disorder. They mentioned pretty much those are the mental health diagnoses you see alongside most co occurring disorders. Pretty much everything that we see in a mental health can be a co occurring disorder. States that one of the issues with co occurring disorder is that people who have undiagnosed or untreated mental health disorders will self medicate their symptoms. I thought this was interesting because we talk about the usage of drugs to self-medicate, and we also talked about in class like is it them self-medicating, is it an actual concern, is it affecting their day-to-day life, which is interesting. One of the other sources that I'm going to talk about actually mentions that as well. And it also talks about individuals feeling depressed or having anxiety when dealing with withdrawal. So, and again, when another source, they actually talk about the fact, are we seeing withdrawal or are we seeing anxiety? And how are we diagnosing that? If we're going to be treating someone's withdrawal and we're saying that's anxiety, then we're might not understand what the individual is actually going through. Um, some of the data of co-occurring disorder in 2022 was 21.5 million individuals live with any mental health disorder and substance use disorder. And then they said 7.4 million of those had a serious mental health disorder with substance use disorder. An interesting fact was they said 12.7 million of those having co-occurring disorders received one or the other treatment. So they either got mental health or they got substance use treatment, but not both. There was only 3.7 million received both services within 2022. They also mentioned that some mentioned that most providers do not feel cross-trained enough, creating a barrier for treatment. It's kind of something that I saw echoed throughout a lot of the resources is that most people don't feel like they're able to support individuals with substance use disorder because they're not effectively trained in that. They're mostly just trained in the mental health aspect, which I thought was very interesting considering that most people will look at substance use disorder still as a mental health concern. So why are we not training professionals to be able to handle both? Um, some of the negative outcomes to no care was increased self-harm risk and people with untreated co-occurring disorder present with a history of homelessness and incarcerations. So if we're seeing people that are homeless and incarcerated, they're obviously not getting their first base of needs, which is shelter, food, like met. So yeah, we're going to go and find people that are going to have more co-occurring disorders, especially using substances to for a sense of safety if they're homeless and incarcerated, not getting their needs met. Some of the overview of treatment barriers that they mentioned and some of the solutions that will come with that are some of the barriers were failure to provide routine comprehensive screenings and assessments. Um, if we're not able to identify correctly what an individual is experiencing, if it's substance use or if it's a mental health, how are we going to give them the effective treatment? Lack of training and credentialing. If we're not training providers to be able to handle substance use disorder as well as mental health disorders, then we're not going to be able to provide the services that the individual needs. And then siloed services. So most people will, when they think about how mental health works and also substance use, you hear that this residential is for substance use and this residential is for mental health, or this program is for mental health and this one is for substance use. If we're siloing our services, we're not treating the whole individual in a very holistic viewpoint. We're very chopping up the individual. If we're saying you're going to come here for mental health, you're going to come here for substance use, and there's no connection, there's no continuity of care, we're not giving that individual the services that they need to be able to grow and work on reducing their substance use and the harm that they face from that. Um, the next thing they said was stigma towards co-occurring disorders and behavioral health systems. I found it very interesting that they kind of talked about the fact that even within mental health, they look at the substance use part still with stigma. I kind of thought by now we would have a better understanding within our own community as professionals that that substance use is also a very major illness disease and that we shouldn't be looking at it in a stigmatized lens and we should be treating it as a part of the individual that needs to be treated. Um, Organizational capacities to assess and treat. If we're not provided the means to assess and treat, then how are we giving the individuals the means that they need to get better? That's on an organizational standpoint. We as clinicians can do as much as we need to provide these services. However, if the organization is not providing the assessment tools or the things that we need to be able to provide the individual the services they need, how are they going to get the services? So some of the next things was Medicaid funding and restrictions. They talked about like psychiatrists are less likely to accept Medicaid, and billing eligibility is limited for substance use, and then programs being licensed for either one or the other, but not for both, and medication coverages. Um, these are major concerns because if we can't even get people to get the treatment that they need because we're trying to figure out where the funding is coming from for these people, and we're not having programs be able to be licensed for either for both at the same time, substance use and mental health. They're not going to get the services that they need. Um, then they offered some potential solutions to this, which I thought was very interesting because they said in the topic there was overview of treatment barriers and solutions. I thought they would offer more solutions, but they only offered solutions in this section for the medication coverages. So they said that some of the potential solutions could be expanding the coverage, increasing reimbursement rates, creating streamlined state Medicaid control, credentialing pathways, which will allow individuals to get trained for both substance use and mental health and get the right credentialing to be able to support those individuals. And then provide value-based and alternative payment models. And then they mentioned the Consolidated Appropriations Act in 2023, which eliminated the need of a waiver to receive medication for opiate use treatment, um, which is very interesting because that's just now. Like that was 2 years ago. So we're still making acts to be able to help individuals get the treatment that they need. And then it said people, the other barrier they mentioned was people might not seek treatment for numerous reasons. Are they ready for treatment? Do they want to get better from their substance use? Do they even acknowledge that they have a mental illness? I work with individuals on a day-to-day basis that still will say that they're not having any mental illness, that their voices are not their voices. So when we're talking about individuals who are cognitively be able to function the way that they need to be able to seek the help that they need, we're still battling whether or not they're able to seek treatment the way that they want to get treatment or if they believe that they have an issue in the first place. I thought it was really cool that in this article, they also mentioned the six guiding principles. Little bit basically was that using recovery perspective, holistic viewpoints, obviously making sure that the individual is being viewed as the whole person, mental health, substance use, their environment, everything about the individual is being taken into consideration. Mentioning the phased approach, and then talking about addressing some real life problems that people go through. We need to be able to make sure that we're taking care of the whole person, just like the holistic viewpoint mentioned before said. Plan to address individuals' cognitive and functioning concerns, just like I mentioned earlier, talking about if the individual is able to function at a high level to get the treatment that they need, or do they even know what's going on with themselves? So we need to be able to work with the individual to enhance that part of their beings to be able to work on the issues that they might not feel that they're able to right now. Support this, making sure they have support systems to maintain treatment effectiveness. When they mentioned this, they didn't really mention it outright, but I kind of felt like this was leaning towards the 12 steps, AA and A groups. So a lot of like systemized things that are in their community that they can be integrated with, that they'll be able to use once they're no longer needed for treatment with us, or if they don't need us anymore, that they have these resources outside in their community that they can reach out to. They also mentioned some workforce administrative concerns, the limited amount of providers, the burnout that's experiencing, and the struggle to retain employees. I thought it was interesting that they mentioned this. I thought, like, obviously we know burnout's a big thing, but I thought it was very interesting that they actually outright said it. And they mentioned that one of the things that is cool about that with where we are right now in our field is telehealth having a greater outreach, allowing us to be able to connect with our individuals or more individuals on a regular basis than what may have been possible if they were only coming in person. They had a very, very big, extensive thing on evidence-based practices. In the bottom, hopefully when I make this as a YouTube video, I'll be able to provide the links to all the articles that I've been able to pull up. And if you go into that one, like towards the ending, there's numerous grids of different evidence-based practices that can be used to help individuals, in whether that be for outpatient, residential, community. There's a bunch of those. And what I thought was really cool about those charts is that it includes the duration of services that you typically see, whether it be 6 to 8 weeks, 12 weeks, however that may look, the level of care and the setting that it can be in. So is it a residential service? Is it with us on a one-to-one? Is it in a group setting? And then additional resources. So in the chart, there's hyperlinks where we could click on and it will say, what is this residential thing? What is the purpose of this? So there's a bunch of different hyperlinks that give us connections to that evidence-based practice and how you can see it would be effective with that group. Um, Moving on to the next source I found it from PubMed Central. Um, the article is called Treatment and Substance Use Disorder with Co-occurring Mental Illness. It discusses how substance use disorder is a very concerning issue, and is one of the leading causes of death, as well as the struggle with the healthcare system faces. They also make a significant connection to in the dual diagnosis that is found with individuals who have a mental health illness. And they said that the word dual diagnosis actually comes from the 1970s, around the mid 1970s, from the World Health Organization. And then later on gets into the co-occurring disorders. Um, the article breaks into prevalence of co-occurring disorders on diagnosis. So the major mental health diagnoses that they talked about throughout this article was depression, anxiety, and ADHD. With depression, it says adolescents who have substance use disorders are more likely to have a major depression disorder. Anxiety said studies showed that if there was a lifetime drug dependency, they were about 2.9 times more likely to develop an anxiety disorder. And with ADHD, said it was the variables placed on the different substances. So they said there was twice as likely to have a tobacco or cocaine disorder, about 1.23 to about twice as likely to develop an alcohol use disorder, and then 3 times likely to have a cannabis disorder. They mentioned a little bit talking about the general risk of overdose, um, which kind of in the flow of the article, I wasn't expecting to see it where it was. It was literally like a little small little blurb, and it just said that opioid use carried the highest risk of overdose. And it said it gave some statistical data on accidental overdoses and expresses the medication related ones occur with depression and anxiety disorder. So like I said, this was a very small little blurb and it kind of felt out of place. It almost felt like they were just trying to give additional information. But that additional information is kind of relevant for us to know that individuals who get placed on medications to help with their depression, anxiety might be a concern if they start using prescriptive medications to self-medicate more than what is allotted to medicate them, what is prescribed for them. Um, Moving on with the next topics, they were saying that it discusses that co-occurring diagnosis makes it harder to treat the individual because they kind of cover each other up. They kind of go further into this when they break it down to each one. It says it gives an example going through withdrawal that can present as agitation or a mood disorder. However, they're just going through withdrawal. So, like I said earlier, when we were talking about the website's article that I was talking about, we need to know what we're actually dealing with. It may look like a substance use issue and it could be a mental health one. It could look like it's a mental health issue and it could be a drug issue. So just knowing what we're kind of facing with, making sure we're asking the right questions to kind of prod and find out exactly what is going on with the individual. We don't know what's going on with them unless they tell us. If they're expressing that they're having these agitations, is it coming from withdrawal, and how do we gauge or assess what their withdrawal symptoms are, and if they have that anxiety disorder. Then it expresses that the best treatment to integrate is an integrated treatment approach, which we've all know that the best way to handle both diagnosis is to treat both concurrently. So it said the physicians must use both pharmacological and psychotherapeutic approaches effectively. For example, with depression, this may look like treating the individual in the context of substance use, but altering the treatment for the symptoms of the severity that the individual is experiencing. So making sure that we're treating the substance use part of it, but also making sure we're using interventions from the psychotherapeutic values that we have to make sure that we're handling their depression levels that they're experiencing. Some of the psychotherapy interventions that they mentioned that could be used are CBT, MI, 12 step, and then it said community reinforcement approach, just to name a few. Like I said, from the SAMHSA website, they did offer charts that have all the different evidence-based practices that are generally seen when working with co-occurring or substance use issues specifically. So we can always go refer back to those charts and see which ones also work. But just to name a few, they mentioned these are some of the interventions that you might see used when working with substance use and mental health at the same exact time. For anxiety, they mentioned that the medication can be helpful. However, long-term effects are not certain. They said, I think it was buspirone, or I don't even know how to pronounce words. I'm sorry, don't know medication like that. But expresses that CBT is best for this treatment. So someone with anxiety using CBT, which will focus on behaviors and the cognitive functioning as the reasons as to why someone's doing that, understanding that a little bit more, giving them interventions to work through. It will be helpful to decrease the anxiety that they have, which will ultimately also help maybe decrease and reduce the alcohol or drug of their choice consumption. They express there's a difficulty with ADHD though. They said that substance use disorder and with ADHD and substance use disorder, it's kind of hard to understand if it's ADHD or if it's substance use disorders symptoms. And they said that the best way to go about this is kind of to go back at look at their history and their childhood. Is this an issue that's in most of their paperwork from when they were in school? Is this something that has always been existing? And was it medicated before? Was it not? These are things that we are looking back at because it's kind of hard to diagnose that's ADHD at a later age, especially when there's substance use also occurring at the same time. They mentioned that with ADHD, it's kind of the biggest one to either get overdiagnosed or underdiagnosed, which I can understand. If we're not, if we usually see this in childhood and it's not diagnosed at childhood, and we know that children typically also get overdiagnosed sometimes based off of conversations that we've had in classes prior, that trying to diagnose ADHD at a later age when we're also seeing substance use is going to be hard. They also mentioned that the medication usage to treat ADHD symptoms is controversial, especially with people that have substance use disorders because of the addictive possibilities that come with the medications that are being used to treat ADHD. They've said that although this is a major concern, they also said that that's probably the best approach of treating co-occurring diagnosis with that involves ADHD. They said that the stimulant medication based on the symptoms, they said the stimulant medication is the best to treat ADHD symptoms, and that basically the best options that we have for the pharmacological standpoint is to basically monitor through the risk benefit analysis. So if the individual is starting to get better, is it good? Are we seeing improvements with them being on this medication? And if there seems to be a little bit more of a codependency on the medication, or we're starting to abuse the medication, the stimulant medication that's being prescribed, then we might have an issue on our hands, and we might have to start working on treating the substance use part a little bit more, especially since that can be kind of life altering. Lastly, I found this article from the Hazelden Betty Ford Foundation organization. It's called "I'm Struggling: Is an Addiction or a Mental Health Disorder?" Thought this was very interesting when I was just looking at different websites to possibly um, use articles from. And I thought it was very interesting because the website also offers the different like facts and tips throughout the websites of different signs and symptoms that each drug offers. So for someone who may not, that has a family member that might not know a lot about drug use or know about a lot about substance use or whatever, this could help them be like, if they know that the person's drug of choice is cocaine, there's on their website, they give you some signs and symptoms to look out for, and if it's going to be an issue or how they get that individual help. It's very much looks for the family aspect as well. But with the article that I found, it says it offers talks about co-occurring disorders and offers information on what mental health disorders are, as well as addiction. With mental health, it states that some different diagnoses they give a definition of mental health illness and causes the disturbance of cognition, emotion, behaviors. Very much what we already know of what a mental health illness is, but it gives that description. So for individuals or family members who don't know much, this is a kind of like what I would say is not the most like clinical, like we are scholars reading this, but it's more like this is a resource that could be identified that most families could read up on and understand a little bit more. And it's not very hammered down with the clinical language that we usually see in articles. Um, it started, as I mentioned, states, and it's mentioned with addiction. It's very similar, like I said, very similar from the book. It says involving patterns or symptoms caused by using that an individual continues to engage in despite the negative effects. Very straightforward from what we had in our books. When talking about co-occurring disorders, it gives other name of dual diagnose. So, like we said, it came from dual diagnose to co-occurring disorder, kind of used interchangeably. In 2018, the National Institute of Drug Abuse report stated that out of 42.1 million adults with a mental health diagnosis, um, a little over 18% also had a substance use disorder, which is kind of staggering numbers to me. Like the fact that we're talking about tens of millions of people being affected by mental health and also now being affected by substance use concurrently is wild that we don't have services like fully fleshed out for these individuals and we still have stigma towards substance use disorder. It discusses the difficulty identifying which diagnosis came first. Ultimately, we all know that it doesn't matter which diagnosis came first. We're treating the whole individual. And they even mentioned that they expressed that the ideal treatment is to treat both diagnoses at the same time. So I thought it was very interesting that they even brought up the fact that it can be difficult to find out which diagnosis came first. But ultimately, we really know it doesn't matter. We treat the whole individual. It also gave a list of different substance use disorders typically seen. It actually included tobacco use, um, as well as all the other ones that we know: alcohol, opiates, stimulant, marijuana, hallucinogens, prescriptive drugs. Um, they actually had a section for saying drinking slash using because addiction or mental health. And it talks about the usage and stating that people may not actually have a substance use disorder and the importance to discern if drinking or using is impacting other areas of life in a pattern. Um, like we talked about, if someone's experiencing is moody, are they actually going through withdrawal or are they having, or is that just a part of their mental health if they have a bipolar disorder? Or if they're going through withdrawal, do they have a bipolar disorder? We need to make sure that we're aware that we're looking and assessing for both different diagnoses because not at all times do we see these things be, yep, that's a mood disorder, or yep, they're going through withdrawal. We have to know what we're looking at. Um, and it says it gives two questions for people to ask themselves. It says, am I using to self medicate or am I using to get through a stressful day or day to day situations? So, although we know self medicating off of opiates and alcohol and stuff like that is not good, but is it impacting their life in a way that is more than just getting through one rough day? Is it impacting their life to the point where they're not going to work because they're drinking or using opiates so much? So, like I said, this one is more for like the people that don't that have a family member that don't know what's going on, kind of can read through it. It's a little bit that like easier language. And for those who might be questioning, do I have an issue? But it's also good for us from a clinical standpoint to be aware of these different things because we might be so bogged down knowing our language and being able to talk to one another that we forget that there's an individual across from us that has no fucking clue what we're talking about. Um, and it discusses the understanding of the reasoning as to why you're using substance might be helpful to identify areas for improvement and to reduce usage. So, like it's saying, even though you might not have like a substance use issue, understanding why you're doing it might help you be like, okay, let me handle my anxiety a little bit better, and I might not be drinking as much. And that might be the fact that they don't have a substance use disorder. They just had an anxiety problem that was causing them to drink a little bit too much, and that they just had a poor relationship with alcohol for a period of time until they got a better handle on their anxiety. And to wrap up this last one, they talk about accurate diagnoses, like I've been talking about throughout it, making sure that we're actually giving the person the right diagnoses that we're seeing. They said to make sure that when you're looking for an accurate diagnosis, to make sure you're going with a licensed professional who's trained in not only mental health but also substance use disorder. If you're seeing a mental health professional, they're only going to be able to tell you if you have a mental health diagnosis. They're not going to be aware that you're telling them that you're drinking and that that's an issue for them. They might be like, "Oh, that sounds like something for substance use, but I'm only here to look at the mental health. That's all I'm trained to do." So if you believe that you have a lot going on, seeing someone who's trained in both, you'll be able to understand. They'll be able to look and discern if you have both, or if you have one, or you just have a poor relationship with alcohol at this point. They said there's some emotions that are tied to getting a diagnosis. They said you could feel that it could feel very validating. You can feel that you're not alone and that you can find effective treatment. So I thought it was very nice that they wrapped up stating that these are the things that people might be feeling once you get a diagnosis that's accurate to your situation. Um, so yeah, that's pretty much my wrap up of what I've looked at through the three different websites about co-occurring disorders. Is severely needed. Um, I feel like right now we don't do a good enough job to treat people the way that they need to be treated, and that we need to kind of up our ability and our knowledge to be able to help those who need the help the most. Um, it's too often that someone comes in through our doors that has both a mental health and a drug issue that we can't service because we only focus on mental health where I work. And it's kind of shitty. So hopefully, through this experience, I'll be able to help individuals to have both because it's too often that it's coming up. So yeah, thanks.